So first, we would start off by doing our pre-procedure steps. After that, we will go ahead and bring it to the patient. I will look at the patient and make sure that they are well developed, well groomed, and well nourished. The patient appears to be alert. Now we'll test their orientation with a few questions. So, do you know who you are?
Yes.
Okay.
Larry Oden.
There we go. Do you know where you are?
Yes.
Okay. Do you know what month it is?
March.
Yes, it is. And you know what we're doing here today?
We're taking a head-to-toe assessment.
Yes, we are. So after that, we will go ahead and, or after our orientation and the patient is alert and oriented ×4, we will go ahead and check their vitals, their vital signs. We will get their weight, their height, their BMI as well. With blood pressure, we want to make sure that systolic is less than 120. Diastolic, we want to make sure it's less than 80. For respirations, 12 to 20. Heart rate, we want that to be 60 to 100. Let's see. Then temperature, 97 to 99. And then for SpO2, just regular patients, we can expect that to be 95 and up. If the patient has COPD, that range could be a little bit lower, around 90. So then after that, then we got our height, weight, and BMI. Then we will go ahead and do like a quick pain assessment. So I would ask them the PQRST. If you had any pain, does anything make it worse or better? I'll ask about the quality of the pain, whether it's sharp or chronic or dull or anything like that. Then ask if the pain radiates. Does it spread, and if so, where? Then ask about the scale. On a scale of 1 to 10, how would you rate it? Then time lapse would be like, does the pain come and go, or is it constantly just sitting there? So then after that, we would do our skin assessment. And if you don't mind just raising up your sleeve for me. So we would check to make sure that the skin color is appropriate for ethnicity. Check to see that the skin is warm to touch. Turgor returns less than 2 seconds, and that the skin is smooth and dry, and there's no, thank you sir, there's no edema, no lesions, no erythema, no scars, rashes, or echinosis or cyanosis. So then after the skin assessment, we can go ahead and check if there's any, probably has an IV. Make sure that the IV is intact and patent, and that there's no, wherever the IV is at the site, or let me see your hand, say if it's at the hand, make sure that there's no tenderness at the site, no drainage, no erythema, no edema, or I said drainage, yeah. And no tenderness, I believe I said that as well, okay. So then after that, if the patient has any wounds, this patient does not, but if they did, we would make sure that the wound is well approximated. If there was any, if there was any stitches or any staples used, make sure that the wound is still intact and that the staples are intact. Make sure that there's no drainage, erythema, edema, or tenderness, or or any tenderness to it. Then check the IV, or check the drains. We'll make sure that they are also intact and patent. Then that there's no drainage, no odor coming from the site, and that there is no tenderness or edema as well. Then after that, we will go ahead and check, then we can go ahead and enter our head to toe. So we will first start off with the hair. Our hair is evenly distributed and is appropriate for age. Then we would look at the head. The head is normal cephalic. It is with no masses or any apparent lumps. The eyes, and you can just look at me, sir. Eyes Eyes are symmetrical in proportion to the face. Then I would take a pen light and then shine it into his eye, and then check for perla. The eyes or pupils are equal, round, reactive to light, and accommodate. Then we would also check for visual acuity. Just tell me how many fingers you see.
3.
3. And then
4.
all right, thank you, sir. And then also follow the tip of my finger. Don't move your head or nothing. Just use your eyes. Follow the tip of my finger. There we go. Okay, so visual acuity is intact. Then next we go to the ears. Ears appear symmetrical and proportionate to the head. We would then do a hearing or whisper test and just repeat the words that you hear.
Basketball.
And then
Football.
there we go. So hearing acuity is intact. Then I would take my otoscope and I would lift for adult patients. We lift their ear up and back. So for him, I would lift up and back, and then look into the ear canal. Make sure that both tympanic membranes on both sides are pearly gray, and that the light reflex and landmarks are intact, and there's no perforation or any extra cerumen coming out. The next we go to the nose. When the nose appears symmetrical and proportionate to the face, then I would I would have like an alcohol swab on me or something. Then I would ask the patient just close their eyes. You just close your eyes for me. We'll just demonstrate it. Just close your eyes and then close one nostril for me. Close one nostril for me. There you go. And I would just have a alcohol swab and then have him tell me what he smells. He will say alcohol, then he'll switch nostrils, and then he'll say alcohol. And then we would note that the smelling acuity is intact as well. Then next we would go to the mouth, and then sir, just say ah. I'll take okay. Well, hold your mouth open for me. So then I'll take the pen light, and I would note that the buccal mucosa and gingivae are pink and moist, and there's no exudates. The teeth are in good repair, and the tongue and uvula are midline. Then after that, we would go into the neck. If you could just turn your neck to that side. Okay, and then look towards me. Okay. There's no noticeable JVD or jugular venous, there's no noticeable JVD. The trachea is midline, and the thyroid is non-palpable. We could also check the carotid arteries, make sure they are 2+ and equal bilaterally. Make sure not to do them both at the same time. You don't want the patient to pass out. So after that, we would go into the chest. First, we would inspect the chest. If they were wearing a gown, I would remove the gown so I could see the actual skin of the chest. Check the integrity of it. Make sure that there's no any scars, erythema, any masses, any rash or lesions like that. And make sure that the chest is symmetrical. So for that, I will put my hands right at the rib cage and then just say, sir, take a deep breath for me. All right. So there's symmetrical chest expansion. The patient's breathing is even and relaxed with no signs of acute distress. There's no nasal flaring, no retractions of the intercostal muscles, no use of the accessory muscles. So then after that, we'll go ahead and auscultate our heart sounds. So originally you don't want to listen over a shirt or a gown. You would just kind of, okay, yeah, all right, that's fine. So we will listen. Okay, we'll listen to our 5 heart sounds here at the aortic position, and then at the pulmonic position, Erb's point, tricuspid, and the mitral position. You go ahead and put your shirt down. So we will note that at the mitral and the tricuspid positions that we listen for S1. At the Erb's point, we listen to at the Erb's point, we listen to S1 and S2, and at AP or at the aortic and pulmonic spots, we listen to the S2 sounds. We would note that the rate and rhythm was regular, or we would note whatever the rate and rhythm was. Also, if there was any extra sounds, murmurs, diminished sounds, or accentuated sounds. The next we would go into our respiratory sounds. We've already checked to see that the patient is not in any acute distress. So you can actually lift your shirt up again if you don't mind, sir. We listen to our 5 spots in the front. So we will start up here. And each one they would take, you don't have to do it because I don't want you to get lightheaded right now. But each one we would let them take an inhale and then exhale. Okay. So we would do one up here, and then 1, and then 2, and then down to 3, and then 3, and 4, and 4, and then 5, and 5. Okay. Then next we'll actually we'll need to do our 9 posterior breath sounds, so we can actually you can just stand up real quick and we'll do that. You don't mind taking your jacket off. All right, so turn towards the camera for me. So we'll make sure to stay in between the scapula and not to listen over the spinous processes. So listen up here, take a deep breath in and out. 1. And remember, don't go too fast. It's 2. And also that you don't even have to do it, we'll just count it 2. Then 3, 3, 4, and 4, 5, 5, 6, 6, 7, 7, 8, 8, 9, and 9. Alright, so after we listen to our 9 posterior breath sounds, you can go ahead and take a seat for me. We will note that the breath sounds are clear and there's no adventitious sounds. And then after that, we will go ahead and enter the abdominal assessment. Yeah, that's fine. So you just don't mind raising the shirt. So first we would inspect that the stomach is flat and smooth, that there is no lesions or ecchymosis, scars, any striae, or any noticeable peristalsis going on. So after we inspect, we would auscultate them. We don't want to stimulate peristalsis, so you want to auscultate the abdomen second. So we'll start in the right lower quadrant, and then the right upper, and left upper, and then left lower. Then we would note, you go ahead and put it down, we would note that we hear normal active sounds or hypo or hyperactive sounds. If we don't hear any sounds in that particular quadrant, we'll re-listen to that sound or to that quadrant for 5 minutes. Then after that, we would palpate actually. So, sir, you don't mind if I palpate the abdomen, the stomach. So we will palpate, starting soft palpation in the right lower, and then right upper, left lower, or left upper, and then left lower. And then if there was no pain and no noticeable organomegaly, we would go with deeper palpation to make sure that there was still no pain or organomegaly. So go deeper with it in each quadrant, starting with the right lower, and then right upper, and left lower. So after that, then we will go ahead and check our peripheral vascular and neurovascular. So we've already checked the carotid arteries in 2+ and equal bilaterally. Next, we will go and check the arms. If I can see your arms, sir. Check to make sure that the brachial pulse is 2+ and equal bilaterally, and then radial pulse is 2+ and equal bilaterally. And you would do the same, of course, on here, brachial and radial. And then we would also check their femoral artery. It's a bit invasive at times, so sometimes we don't check for that. Then if you can come over here, and we'll show what the popliteal artery is. Popliteal artery under the knee. Then we'll check. We'll check the posterior tibialis, and then the dorsalis pedal pulse right here. So then after that, we make sure that everything is 2+ and equal bilaterally. We would also check the nails. If I can see your nails, sir. We would make sure that the cap refill is less than 3 seconds, that the nails are strong, there's no excessive brittleness or thickness to them. And so if you can put your nails up like this for me, or just like together, just like that. Just bring them together like that, okay? There's no clubbing of the nails, no ingrown nails or anything like that. There's no cyanosis at the nails, and there's no noticeable erythema scars. So after that, we would also test for sensation, have like a little bit like something sharp to point each hand, arm, leg, and feet. So we would test to make sure that their sensation is intact. everywhere and that there's no paresthesia. I would ask them to raise their arms and then raise their legs to check that there was no paralysis. And then after we've confirmed that, then we do our genital urinary. Don't want to skip that part. So I would ask when, you don't have to answer these, sir, but when was your last bowel movement? I'll ask when was your last urinary output. I'll ask, were you feeling any constipation, any diarrhea, vomiting, any nausea occurring, any pain upon urination, dysuria, any blood in the urine, which is hematuria, and note the frequency and the urgency. If there's like, does it hit hard and you got to go now? And if there's any incontinence. So after the genital urinary, then we'll finish up with the musculoskeletal and range of motion. So we'll test the neck. Sir, just follow the movements that I make. Just flex the neck, extend the neck, bring it up, then circumduct, which is just kind of bring it around town for me. There we go. We will note that there is no crepitance and no pain. Now don't let me, now keep your neck still and don't let me push it. Okay. Don't let me push. Let me push. All right. There's no pain and no weakness in the neck. Then I would ask the patient to abduct the shoulders, bring them out. Now don't let me move them. Hold them still. All right. Don't let me move them. Don't let me move them. And then raise them up. All right. So then strength is strong in the shoulders. There's no crepitance, no weakness. Roll flex at the elbow. And flex your arms up. Extend your arms down. Then bring them back up. And now I'll test grip strength. I just put my fingers in between your hands. You squeeze as hard as you can, or go ahead and let me in and squeeze my fingers. All right. So grip strength is 2+ and equal bilaterally. Then after that, we would test the hip. So if you don't mind, we would actually stand up for this last part. Or you come on this side so we can see you. So for the hip, we're gonna abduct the hip by bringing it out. So go ahead, just hold on to that, hold it out, and then kind of circle it, circumduct the hip. Then stay right there for me, sir. Go ahead and keep that leg still and straight for me. Don't let me move it. Okay. So then we will next test the knee. Just have the knee just slightly bent. Extend the knee, flex the knee. All right. Then we will keep the leg up. Plantar flex the foot, then dorsiflex the foot, bring it up, and then circumduct the foot. So we would do that on both sides. Make sure that it's equal bilaterally, and that there's no crepitance or any weakness. So one more time with the foot, I'm gonna ask that you press down. As you press down, all right. Then don't let me push up, and then don't let me